So starting at the beginning, modern scientific discourse and medical models clearly show that there are three main drivers of addiction behavior. This has been discussed for decades now, and really all mental and emotional health issues, not just addiction. So it's known as the biopsychosocial spectrum. I imagine that some of us here, especially those of us who work in clinical settings, are familiar with this. It's long been accepted that biological, psychological, and social factors must each be addressed in order to cultivate an effective treatment environment for addiction or other mental health disorders. So I kind of want to break this down piece by piece. In our existing ecosystem, we have a pretty, making sure you got the right slide here. You see the biological one there, right? We have some pretty robust resources already in place for addressing the biological aspects of substance use disorders. Right? We have medication, many different kinds of pharmaceutical solutions for treating underlying mental health issues like anxiety and depression. We have medically assisted detox facilities and procedures for helping people end their physical relationships with drugs and alcohol. And of course, we have medication-assisted treatment programs to provide medicines like Suboxone and methadone to support people both in physical withdrawal as well as providing long-term harm reduction and safer substitutes if that's what's best of service to the person. We also have some pretty robust infrastructure for addressing the psychological factors of mental health challenges and substance use disorder specifically. We have treatment programs that include a wide range of one-on-one psychotherapeutic techniques. I was talking to a therapist friend recently who said that they, during their coursework in undergrad and master's, I think, were exposed to some 430 different therapeutic techniques. We have a lot of different ways of understanding the human psyche and using that information to help people make changes and grow and heal. We have lots of cutting edge trauma intervention techniques now, like EMDR therapy. There's lots of different flavors and formats of process groups and group therapeutic modalities. And we have short-term and long-term residential treatment facilities that really focus on therapeutic modalities as their primary method to delivering treatment. But the question that we're here to ask today is, what about this social component that is, in theory, equally important to these biological and psychological factors in the spectrum model? What systems or services do we have within our treatment ecosystem for addressing social health? Before we try to figure out where it is, let's start with just a general definition. The way that I'll define it for today's presentation is that social health is a way to refer to an individual's capacity for interacting and forming meaningful relationships with others. It's, this isn't a very clear or measurable definition, but it's something that everyone understands as intuitively important to a person's process. If you work in treatment settings or if you are a clinician or peer support, this is something that we understand as critical to people being able to really integrate treatment, right? And if you're in recovery yourself, like me, you, again, just intuitively know that this is a part of changing patterns and becoming more well, our social networks and the quality of the relationships that we have around us. But from that kind of basic definition, we have a bunch of other things that tend to fall under the umbrella of social health as we start to think about it. We have a whole body of theoretical framework that actually doesn't have very much to do with the quality of individual relationships, as much as it has to do with how public health entities can use social experiences to drive behavior changes. There are a couple of well-known models that leverage social rewards to motivate people to engage in certain health behaviors. These are like the kinds of theories that public health organizations will use to initiate smoking cessation campaigns, for example. How can we use social rewards to drive behavior changes in people? The most commonly known one is probably the TTM model that's shown here. Many of us may have heard of it. This is the model that understands how behaviors can be seen through the lens of pre-contemplation, contemplation, preparation, action, and maintenance. Social health from a public health perspective is one other body of knowledge that we can kind of loosely associate with this idea of social health as a part of this, as we try to figure out our answer to this question. And then the other body of knowledge that we have, which kind of feels like another hard left turn, is this idea of social determinants of health. And now this is a model which helps us assess an individual's overall environment and social context in order to determine what factors those or what effect those factors have on the individual's capacity to experience health, or even just to make healthy choices to begin with. Social determinants of health include things like socioeconomic status, gender, environment, access to education, access to healthcare, and things like that. So first of all, when someone is presenting with some kind of mental health challenge or a substance use disorder, and they show up for treatment of some kind or are seeking a solution within the system, within our treatment and behavioral health ecosystem, often the social health part is just skipped altogether and there are no questions asked about it. But in the cases where practitioners do address social health, the way that it's typically accounted for is simply to ask questions about a person's home life, about their social behaviors, and possibly about greater social determinants of health that are active in their experience of their community. So if practitioners remember to ask these questions, and then the patient maybe reports that they live in a residence with other family members or friends, or that they attend church or a fellowship meeting regularly, then these boxes get checked and they meet the criteria for having a healthy social context. And if the boxes don't get checked, then generally what's recommended is that they join a group. Maybe the caseworker even goes out of their way to help connect the person to one. But if this is working and this way of addressing social health is the best way, then why are so many people experiencing loneliness in this country? According to research that was published earlier this year, pre-COVID, 3 out of 5 Americans report feeling lonely. And those who don't associate themselves with that word, more often than not, on the same survey will report feelings of being left out, poorly understood by the people around them, or just lacking companionship in their life. And even if we're not asking about loneliness directly through surveys, I think we can just look and see objectively that social health in this country is suffering, regardless of whether people check the boxes for having social interaction or not. Technology trends and modern social structures are changing so rapidly that our culture for connecting with each other really hasn't been able to keep up. Just for example, we rely heavily on social media and technology-based communication for the majority of interpersonal encounters. And for many people, it's the majority. There are also widespread cultural trends around privacy and individualism that have kind of normalized this experience of social anxiety when we're around strangers. And many opportunities for developing meaningful relationships in the workplace have actually just been eliminated either through teleworking, through automation trends or gig economies. And modern family social structures have just really changed a lot in the past 100 years, especially in ways that do tend to drive loneliness and isolation. In one survey that was published by the Pew Research Center last year in 2019, we saw that more than 4/5 of American adults said that getting married is an essential part of living a fulfilling life, which is fine, if it's just the institution of marriage that we're abandoning and not relationship. But unfortunately, that statistic is supported by another one that says how 33% of Americans ages 18 to 34 were living without anyone at all. And just 10 years later, in 2018, that number was up to 51%. What we're really seeing is that experiences of meaningful human connection in this world that we live in are just increasingly scarce. And so what is it that we're really missing? What I'm most curious about is why our awareness of all of this as humans living in this world, and, then as folks who are addiction professionals and those of us working in the mental health services industry, why hasn't our awareness that social health is important created infrastructure that actually solves and addresses social health problems? And I think the reason really that we're starting to see is that our strategies so far have been set up to check on the social environment of individuals in order to assess how well that individual human is interacting with other people or not interacting with other people at all. We simply evaluate the presence or absence of a social context in a person's life, but we don't evaluate the quality of the connections in that person's social context. We don't look at how relationships within the community are functioning. And, that very well may be because we don't have a treatment environment that invites the whole community to show up for an intake meeting, right? It's a difficult thing to assess. But as a result, we don't know if people who are struggling with addiction issues or other mental health issues are a part of communities or groups that are rife with conflict, for example, or if stigma and shame is so consistently present in their relationships that it prevents meaningful connections from being formed. Now, I want to say that it's very important to understand at the same time what the economic and social constructs that affect a person's community look like from a social determinants perspective are. But to fully assess the social health of an individual, it's equally important to ask this question that we just haven't been asking. What is the quality of relational health in the community that this individual is a part of? We have largely been reducing our social assessments to the environment, that a person's social context isn't just the influence of external conditions. It's also the reality of internal conditions and relationship dynamics, which can't really be assessed at the individual level. They have to be assessed at the community level. So, like I said, while I'm not saying it's not important to ask these questions, it's deeply important to check on the presence or absence of a social context in a person's life, and even more so to devote political energy and funding to addressing inequalities and social determinants of health that affect individuals so severely. And at the same time, it's also extremely important that we start zooming out and assessing the relational dynamics within the communities that individuals belong to, and notice how things like empathy, mindfulness, self-disclosure, and non-judgment between individuals are a part of creating environments where individuals can actually thrive. And this inherently means that we have to also start to notice how, when these elements aren't present, and I'll explain more where I picked these four from in just a moment. But when elements like these aren't present, communities are less cohesive and less mutually supportive, and therefore less healthy for the individuals who belong to them. When shame, stigma, ineffective communication skills, or cultural norms for ineffective communication are present in a group, then the relationships within it can actually create negative health impacts on individual members that's honestly outside of their individual control. So I really believe that we need to start embracing this idea that while addiction is certainly a disease that affects the individual, we understand that really deeply already, right? We can understand how addiction and other mental health disorders exist in the brain and how they affect brain systems. And it is also a disease that affects communities as a whole in a very real way. And community level diseases require community level treatment approaches. So today, my intention is to propose this relational model of social health, which complements our existing understanding of social health as an environmental assessment. You can understand this as a part of the greater umbrella of social health theory, which I described earlier, encompasses a number of different things beyond relational components. This relational model can really just serve as a guide for us to assess relational dynamics within groups when we have concerns about the individuals within that group. And what we've seen is that there's 10 factors specifically that can be assessed at the group level. Non-judgment, which you can think of as the absence of stigma or the absence of shame, or at least a continual minimization of shame and stigma. Mutuality, which means non-hierarchy, or at least an awareness of power dynamics in a group and how they're creating shame through power over, power under experiences. Empathy, self-disclosure, which you can also think of as vulnerability, or both parties having the permission and freedom to speak to what's really happening for them, which often isn't the case in treatment environments, especially, right? Conflict support, intrinsic value, meaning that the relationship or the conversation or the interaction itself is not driven by an outcome or an agenda or a transaction. So neither person is buying or selling something from each other, that there's some intrinsic value of simply having the conversation or the relationship for the sake of that conversation and relationship. Authenticity, secure attachment, mindfulness, and transpersonal awareness, which really just points to how, to this understanding of the health of the community reflected through the health of the relationships within the community. So I'm not going to have time to go deeply into every single one of these during this presentation, but this material will be available for you after the end of the conference on Monday. And I'm happy to provide more information as needed. What I want to leave us with here right now is that we can determine the presence and quality of each of these factors in a social group by being present with groups and communities, by analyzing conversational dynamics, by getting individuals' subjective assessments of their relationships with others in the group, by observing conflict situations, how they're handled by the group. And I also want to underline this point that I've already made, really, that this model fits into the larger model of social health and social health theory that we've already talked about, specifically social determinants of health. Functional group and relational dynamics as described here by these factors in the relational model truly require individuals to feel economically, physically, and psychologically safe first before these kinds of healthy relational dynamics can be fully expressed. What I do want us to consider with this information, though, is that we can and should really be working on both at the same time. It's not clear yet that there's a linear relationship between establishing social determinants of health so that relational dynamics can thrive within a group. In fact, there's actually some pretty good evidence to suggest that the two are really symbiotic, that as we implement destigmatization efforts and relational programs to educate communities about healthy communication and social health, that solutions for social determinants of health problems actually begin to arise from the community itself. So now that we kind of have our arms wrapped around what this idea of social health is, and specifically from a relational perspective, I want to zoom in a little bit further into addiction specifically, and how we can understand the social health model in relationship to substance use disorder, and specifically how it might influence our approach to treatment. I also want to just keep an eye on the chat. If y'all have any questions as we're going through, please feel free to throw them in there. I have the chat over here on one side of my big screen, and I can answer anything as it's coming up. We'll also have a little bit of time at the end for some Q&A. So as you think about social health in the context of addiction behavior, I think that in a lot of ways, it's pretty clear already how much social interaction drives addiction behavior, especially for those of us who work in the industry. There's a lot of evidence to suggest how the same brain systems that drive our dopamine-seeking addiction behaviors are intricately connected to our social reward systems. I think many of us are probably familiar with the famous rat park experiments that went viral on the internet a few years ago. And we're just simply starting to understand more as a global and national community, how addiction is less a function of simply being exposed to a chemical, as it is a function of a person's social context and what our experience of the world is like when we're exposed to a chemical, either our social context or our context for trauma, and what our experience living in the world has been up to that point. So it's really not a surprise that the opioid overdose epidemic has been worsening in parallel to this global loneliness epidemic we've been seeing the past 20 years. In another study, this is a different one from the one I cited earlier, but in the 2018 study of loneliness that had a sample of about 20,000 people, 47% of respondents reported a feeling of being alone or left out. And right around that same time, the CDC estimated that 44% of Americans had been or were bonded to opioids or opiates of some kind at the time of polling. And I'm drawing a simple correlation here between those two graphs, but I think that we can all kind of intuitively understand some kind of relationship here. And we're seeing that correlation reflected pretty clearly in the circumstances of this year's pandemic as well. Public health quarantines created a degree of isolation this year that is even more acute than the loneliness and psychological isolation that many individuals were already facing within the breakdown of modern structures and such that I was describing just a few moments ago. That the data is still being compiled, but at first pass, the American Medical Association estimates that 40% of US states have seen a statistically significant increase in opioid-related mortality so far this year. And that's not to say that the other 60% haven't. It's just that we don't have data from the other 60% of states yet. And we're seeing some pretty sobering local examples, like in King County, Washington, where overdose rates related to fentanyl from April to June of this year were more than double what they were for the same time period last year. So knowing this relationship between social isolation as well as our biological and psychological understandings about addiction, which are still an important piece of this puzzle, right? The social part isn't the only part of addiction disease, but it's an important one to consider in tandem with our biological and psychological understanding. And with all of that understanding, we've been doing our best as a mental health services industry to intervene and stop the tide of overdose deaths, right? And this has involved also partnering with professionals in other systems and social services and criminal justice institutions. But what we see is that when it comes to people who use drugs or people who are caught in addiction patterns, as a society, we seem to have come up with 4 main categories of things to do. We either arrest these people, we give them naloxone or Narcan and safe injecting equipment to make sure that they are staying safe while they're using. We encourage them to start a 12-step journey and join a fellowship, or we might intervene and either help them get to treatment or force a journey to finding some kind of treatment that will take them through the process for 30, 60, 90 days. But sadly, what we see is that none of these things are really working in the sense of overall numbers shifting or the overall trend reversing direction. While these strategies do work in some cases for some people, the overall death rates are just continuing to rise. And like I said, especially in light of the quarantine this year, despite putting people in jail, especially for small-time drug possession, we're really just seeing massive increases in incarceration rates. While naloxone keeps people alive, folks who've survived one overdose tend to be at even higher risk for experiencing another one. 12-step models work really, really well for some people, and they are increasingly, we're just seeing less traction, especially with younger demographics and folks who don't find that particular methodology supportive for them. And the relapse rates that we see post-treatment for opioid use disorder specifically are really, really high. So we really have to ask ourselves, again, what is missing here? And what I want to draw our attention to is this one key word in the way that I've framed the problem here on these slides. It's this word them, that we consider addiction their problem, someone else's problem, not ours. What we really see here, barely noticeable maybe in its subtlety, is a symptom of that relational health model that I was just talking about. That right under our noses and inside the way that we look at addiction and mental health services treatment is some embedded shame. Since addicted individuals are relating with addiction professionals within a group, then having this us versus them construct is a stigma that actually undermines the most important aspects of this relational model for social health that we've been talking about here. So unfortunately, while these methods are working in some cases for some people, they tend to, as a group, kind of focus still on the individual as the root of the problem, or at least the place where we need to focus our compassion and our treatment energy, which really just misses the importance of changing relational structures within the overall community. And unfortunately, what I think is worse is it's not just missing an opportunity, it's actually adding to the struggle in some cases. These things that we try often create more isolation, either physically through incarceration or hospitalization, or just psychologically, creating this dynamic of addicts versus sick people, or addicts versus professional, or normal versus sick, which isn't, by the way, only stigmatizing the addict, but it's also stigmatizing whoever's seeing themselves as normal, right? On the other side of the spectrum, shame gets created in both directions, and in a way of feeling trapped by addiction, we can similarly feel trapped by normalcy or having to show up in a certain way in the world. So if we take another look at these strategies, I'll admit that I am being a little bit dramatic when I say that they never work, right? That's not true. They definitely work sometimes. And the common thread when they do is that us versus them dynamic actually gets dropped. And that then these strategies are offered non-judgmentally in a space of meaningful connection. Connection experiences really are the thread that shows us when our efforts are working and when they're not. And those experiences are marked by the elements of the relational model that I described, those 10 factors that actually help people heal from trauma and gradually shift patterns. There are, plenty of people who have had life-changing experiences while they're incarcerated, for example, and it's usually because they encountered a community, either faith-based or otherwise, while they were in prison, that created a sense of belonging. One of the most powerful things about participating in harm reduction services, if you're an IV drug user, is the genuine, compassionate conversation that you have with other people that don't judge you for what you're doing or why you're there. These moments of connection that are marked by empathy and non-judgment are really what drive change and meaningful change for people. Oops, that's the wrong way. So what I really think we need to be thinking about going forward is, what could our strategies and interventions look like if we just began to refine our capacity for treating the addiction community and not just the individuals who are a part of it, which would include treatment professionals and peer supports and community members, friends and family members. It would include literally all of us, right? Anyone who is in relationship with someone who struggles with addiction or a mental health challenge. This would mean that we kind of turn our view from addressing the individual to how can we all be interacting with each other in more meaningful relationships. some ideas of things we could do. We could create more spaces for the discussion of shared struggles among all members of the community to normalize addiction and promote empathy, to talk about how, yes, you're experiencing this kind of addiction. Maybe I don't identify as someone with substance use disorder, but I know what it's like to binge watch Netflix all weekend long, or how to navigate my compulsions around sugar. We could also implement processes for supporting conflicts that come up between individuals, right, rather than punishing either party, using those moments of conflict to actually illuminate deeper connection, which is what practices of mediation have shown us to be true for years and years. And really, there's just lots of opportunities to generally update our treatment models to recognize the importance of social health and the relational aspects of social health, in order to provide opportunities and activities that prioritize individuals listening to each other, regardless of the role that they play in the system. So now it's still very important that we continue to implement the biological and psychological interventions for addiction. This presentation is not a call for social health exclusively. Medication and psychotherapy are crucial pieces of the individual's journey to recovery, to change, to healing. And it's also still really critical that we, again, devote that political energy and funding to addressing social determinants of health in order to create safety in all the communities that individuals are a part of. And we really have to start implementing this relational model as well. If we think back to that famous rat park experiment, you might remember that for the rats, it was just as simple as taking them out of isolation and putting them in a big cage with other rats in order for them to experience community and get their social needs met. It's not quite so simple for humans, right? We can be surrounded by other people and still feel an acute sense of loneliness. Loneliness describes a subjective feeling, which is really distinct from aloneness and objective physical isolation. There's a big difference between loneliness and aloneness, and the difference really is shame. And that's kind of where I want to take us with the latter half of this presentation. Shame of talking about something, about anything. Shame for showing up and just being a certain way is almost always what gets in the way of two human beings feeling or being able to feel a sense of connection with each other. It's what can make us feel lonely, even when we're in a room full of people, or talking to somebody about the weather. Whether we project shame openly onto the person in front of us through judgment, or we imagine and create shame for ourselves, like, imagining that this person is judging me, or that I don't belong, or that I'm not good enough. However it shows up, it blocks connection. And in truth, stigma and shame are embedded into human cultures for relating around the world, because it has functionally been a huge part of our evolution. It's been used to motivate each other to build and operate the systems that we live in. And as our systems for keeping ourselves and our families safe and well and fed have become more and more robust, and we actually have room to thrive inside of them, we're starting to wake up to the cost of what it took to get here, how hard it is to actually thrive when we don't feel a sense of belonging. So by learning how to implement the relational model for social health in mental health contexts in general, we're going to first and foremost be seeking to identify shame and stigma, and to do what we can or start to experiment with how we can remove it from the social norms, interactions, and relating behaviors that are present and real for whatever community we're treating, or whatever community the individual that we're concerned about is a part of. So I will get into the specifics of some applications, like what this can look like, specifically around the organization that I co-founded that's hosting this festival this weekend, SeekHealing. But before I get there, I just want to spend a couple minutes talking about the single biggest contributor to shame within addiction treatment communities, specifically around substance use. And it's this thing that I have recently been calling abstinence culture. as a cultural norm, it's present in both addiction recovery communities as well as our overall culture as a whole. And I guess I'm wondering, actually, I've been talking for a long time here. Could I just see what y'all think about this idea of abstinence culture, what you think I might mean by that? You can type any ideas that you have in the chat while I grab a sip of water here. Anybody? Abstinence culture. Yes, Amanda, the idea that abstinence is the only path to recovery, a culture that has a tendency to separate. This is the way. Self-righteousness around using anything to cope. I remember we discussed between our core staff the idea of non-prescriptive culture. Non-prescriptive. The expectation that abstinence is the solution. Yeah, you guys are really kind of getting to exactly what I'm trying to illuminate here, right? Resilient, that if you are not clean, then you're dirty and bad. Shame, like the word relapse. That's exactly right, y'all. We can think of abstinence culture as the generalization that altering our consciousness in any way detracts from our capacity to be an upstanding citizen or a productive member of a group or team. So I really like what's being pointed out here in chat, that it's much more than just a relationship to substance. It's more of this prescriptive idea that there is one way, that this is the way, that there's a way of being that's good and pure and a way of being that's bad and dirty. And what we see when it comes to substance use disorder is that abstinence culture generally prioritizes chemical abstinence, but does so somewhat inconsistently. Some social groups, for example, will permit the ingestion of nicotine or caffeine, while, saying that, this is the version of abstinence that is acceptable socially for our group, while stigmatizing the use of something like opiates or alcohol. Other social groups might stigmatize both uppers and downers while permitting the ingestion of sugar, for example, which is also a pretty mind-altering chemical. And we see it in the focus on outcomes in a lot of recovery communities, which is actually starting to shift as this idea becomes more widespread. But what we've seen traditionally is this idea that abstinence is the only or the best path to recovery and to change. Even in some medication-assisted treatment contexts where we're actually supporting people with one substance in order to facilitate change from another substance, there can be subtle and not so subtle implications that it's actually better to not need medication at all, right? The other thing about this cultural norm is that it has this really exclusive nature to it. It's a worldview that aligns hard work and productivity with excellence and frowns on any form of consciousness alteration as detracting from that priority of hard work, of doing better than the person next to you. It creates judgments that define our norms around how we alter consciousness, which apparently is something that requires some level of cultural comment because it's something that humans have done since before we were even fully human. There's some really fascinating modern research that shows that not only humans, but mammals of all kinds are prone to behaviors that alter consciousness. Ronald Siegel, who's a clinical professor of psychology at Harvard Medical School, has published extensive field research on this, showing how everything from bees, birds, cats, cows, elephants, and monkeys all almost universally engage with different kinds of plants that create intoxicating effects, despite the danger of mildly toxic or poisonous effects. Yet, despite this, or maybe perhaps because of it, many human cultures have developed devastating stigmas around altering consciousness. And these stigmas still pervade our mental health and treatment models to this day. We can see overt examples of it. Some of the things that y'all put in the chat, seeing people as dirty or bad, old DARE campaigns and education programs that polarize drugs and alcohol as inherently bad. What's worse, I think, is that we see it, how when we send the message that not only are drugs or substances bad, but that the person who uses them is bad, and that subsequently that person shouldn't be friends with my child or is a bad influence in my family, my group, my school, which is a completely devastating message to send to any human being. We see abstinence culture playing out in how we ostracize people from recovery communities or even their own families if they use that word relapse that Nancy put in the chat, which in and of itself creates some shame and minimizes the space for people to alter their consciousness in any way at all, or to only do so in private or in arbitrary ways that differ from community to community or fellowship to fellowship. Really, we see this cultural norm playing out in the hypocrisy of looking at one's own addictions and judging them as either better or worse than someone else. And I really believe that we see it in the subtle moments where we shame ourselves for altering our consciousness or indulging in whatever it is that we indulge in, right? Even if we don't consider ourselves addicted. The real heart of de-stigmatization, which we talk about all the time in the mental health industry, is it's not just changing our language and how we talk to people who use drugs or people who might be struggling with addiction. It's using our language to actually change our thoughts and how we think about addiction, how we think about consciousness alteration, or really health in general. It's beginning to understand how both addiction and changing our consciousness is something that we all experience if we're human beings. It's not just trying to not shame someone else for theirs, it's acknowledging how that person is actually fundamentally no different from me in the first place. So, we've already discussed how isolation is really a key driver for addictive behaviors and tendencies in a world where technology has been changing so rapidly to affect how often we interact with each other. And, COVID-19 has pushed us into physical quarantine. It's really not a far reach to understand how we're all experiencing isolation in different ways. And since isolation drives addiction, maybe we can then start to see how we might all be compensating for our experiences of isolation with some kind of compulsion or addictive behavior. I'm curious, for another little moment of connecting with each other in the chat, if anyone here started stress baking or drinking a little bit more, if you're not a person who's in recovery, watching a little bit more pornography, doing more online shopping, as those stay home, stay safe orders really dragged on through April and May. It's been hard, for all of us. And I think there's something ingrained in our practice that creates this fear of, if we speak about even things that seem harmless like that, there's a sense of shame that comes with whatever it is that we're doing. I really appreciate and am grateful for some of the vulnerability that I'm seeing here in the chat. Thank you all. I was actually going to invite everyone, if you want, if that's true for you, which I'm already seeing people are naming in the chat, just to write in the chat box, you're not alone. You don't have to name, even though some people are naming specifically what their vices were. TikTok, drinking, stress eating. Yeah. This is a very real experience for all of us. Thank you all for your courage in naming. We are not alone. I appreciate that correction, Sri. We are not alone. This relational model for social health that I'm talking about this evening really depends on the absence of stigma as a first order requirement for relationships to thrive with empathy, vulnerability, and non-hierarchy. So as we seek to implement this model at a community level, we really have to begin with getting rid of shame in ways like this, in ways where we actually signal to each other, you know what, me too. We can start doing this by acknowledging that addiction and mental health challenges are something that affect all of us. It's destigmatizing abstinence culture by providing community education and leadership that just normalizes these experiences, normalizes how trauma and addiction are universal human experiences, and that connection is a basic human need. And the way that this is going to show up in our treatment programs and our infrastructure is that rather than automatically assuming that someone on the path to addiction recovery is striving for total abstinence, that we instead ask individuals what their intentions for their recovery are, and then check in with them as those intentions change, as intentions always do. That's why they're intentions and not outcomes or goals, right? And as we mature, as a national community, as the mental health services industry, we're going to start to deliver on how any of these answers really are okay. And I really want to make the point here that this is not to say that abstinence is bad or something that's not worth striving for. Nor is it to say that holding an intention for 100% abstinence isn't absolutely necessary for many people at the start of a recovery journey. It was for me. For many, going through a phase of total abstinence can be the difference between life and death. It is in and of itself actually a consciousness altering experience, especially for a person who's been altering their consciousness with chemicals for years. Chemical sobriety can initiate all kinds of neurochemical changes that greatly alter our experience of reality. So please let me be clear in saying the opposite of abstinence culture is not non-abstinence. It's just respecting that abstinence is one of many experiences of consciousness alteration that humans can have. The true opposite of abstinence culture are new cultural norms for total non-judgment around consciousness alteration, if that makes sense. Okay, so with the few minutes that we have left, I know that some of you might be popping off at 6 o'clock, excuse me, and the Connection Cafe is opening before the next talk starts at 7:30. But because we got started a little bit late here, I'm probably going to be taking this up to 6:15 if you want to stay and hang out and hear the end of this. And the last bit of what I have to say to you is just sharing some more practical applications of the things that we've been talking about during this presentation. What we're really doing here in many ways with this idea of social health is building a bridge between these frameworks that have traditionally felt really separate of harm reduction and recovery. The bridge is getting rid of shame, right? And understanding how harm reduction and recovery are actually one and the same, and really should be embracing the tools that both communities have available to them. Looking at addiction and substance use disorder through the lens of social health helps us understand how shame is really the driving factor behind the experiences of disconnection and loneliness that lead us to using substances, whether they're driven by trauma or by our simple experience of living in a world that's deeply disconnected. It helps us understand how getting rid of shame and getting into connection is one of the most crucial parts of helping people heal, and that other elements of our infrastructure might not work as well if they're not supported by this social health baseline. So let's just wrap up with a couple of practical applications for these ideas. There are a few examples of programs so far in the world that focus on a social health approach in their delivery. SeekHealing is one of them. This organization that I'm a part of and that is hosting our event here this weekend. We are one of the first models for practical application of social health theory. A couple others that exist that you might want to look up after this presentation are Ventolin in Denmark, the program that connects people with each other in the community to have conversations and meet up with each other for activities. There was also a really beautiful study that was done in Iceland by public health entities in Iceland, or a 15-year study that showed how connecting at-risk youth specifically to different types of social engagements and social experiences directly correlated with decreased risk around substance use. And we are also seeing SeekHealing, this organization that I'm a part of that's based in Western North Carolina, delivering programs and services that are specifically designed to maximize individuals' social health and the social health of the community that the program exists in. Since we started the program, part of its fundamental design is that it engages the entire community as a community treatment program. So folks who say that they struggle with addiction or mental health challenges, as well as people who don't identify as having those kinds of challenges. Since we started the program about a year ago, we've served over 1,000 people. We started the program 2 years ago in 2018. And since then, I've served some 1,200 people. And there's usually some 150 seekers or program participants involved in the program at various levels of engagement at any given time. Among those, about 2/3 are folks who have some kind of history with substance use. I'd say of those 2/3, half are folks who also work a 12-step recovery program and find that SeekHealing is a great complement to their 12-step journey. The other half are people who are looking for an alternative to 12 steps. And within that group of people who identify as having an addiction or substance use history, I'd probably again say about half are people in really early stages of recovery, people who are kind of in the push-pull of detox treatment, sobriety, that kind of back and forth place that a lot of us find ourselves struggling in for a while. And then, another significant group of folks who might identify more as being in long-term recovery, like myself. And then the other third, so that's, the 2/3 of people within the program who do identify as having some relationship with substance. And the last third are people who don't identify as having a substance use history at all, but are involved for other reasons, for the connection that the program provides. Because the focus is connection rather than specific outcomes in addiction recovery, it makes it possible for all kinds of people for anyone really, to get involved and participate. And actually the program itself depends on human beings from all over the community participating so that we can actually get this effect of de-stigmatization and seeing each other all as humans. So really the more diverse group of people that we can attract, the better. And from there, basically, we have all kinds of different little programs and experiments for facilitating moments of connection between people, either in the moment or through sustained relationships. We have a training program called Listening Training that does some actual teaching and conveying information about healthy relationships and communication skills. We have meetings every day of the week where folks can practice relating with each other in ways that are reflected in that relational model that I presented earlier. We pair people up and to meet with each other one-on-one to practice connection and meaningful, healthy communication, and also use technology to crowdsource matching volunteers with people who have needs and connecting them with each other for very practical moments of kindness and connection, like giving each other, bringing free meals to people who need them, or doing check-in calls and visits with folks who are homebound, that sort of thing. So lots of different little experiments within the program, but all designed to promote connection and experiences of healthy relationship, And what we're seeing is that it's really working. I'm going to kind of rush through this because we don't have much time here at the end of this presentation, but a pilot program that we ran in 2018 showed that we have the success metric that we're using being about 87%. And the way that we derive that metric is around assessing whether or not individuals are still following their intentions for their recovery, for their healing journey, as we check in with them over time. So when this data was collected, we had data at 6 months, 1 year, and a year and a half. And 87% of the folks who participated were still following their original intentions, maybe had changed them a little bit, but the original ones still held true. And within that group, about 60% had intentions for total abstinence from all mind-altering chemicals, while the other 40% were some other intention, like medication-assisted treatment or abstinence from heroin, but maybe not cannabis, things like that. So these research results are really fascinating, and this is actually just the tip of the iceberg. If you're interested, you can feel free to send me a message or reach out to the team at conversations@seekhealing.org, and we can share more with you. But suffice to say, it works. And I really believe that SeekHealing is just one of the earliest examples of a model like this. We're going to be seeing more and more popping up in the coming years. And honestly, we can create applications in our personal lives right now. Like leaving this presentation, you can go out there and be a part of the change and improving social health in your community by engaging in your interpersonal interactions, in ways that are reflective of these principles of the relational model. I would really love for all of us to remember that participatory destigmatization of mental health challenges and addiction issues, changing the state of social health in a community, means that we have to engage the whole community and all the relationships in it in order to normalize experiences of mental health problems. It means we have to really infuse every conversation that we have with other people with these tenets of the relational model for social health, not judging the people we're talking to, of being really present and mindful and aware of this conversation I'm having, this interaction, of having the courage to speak up about what's really going on for me and self-disclosing some vulnerability if I feel safe enough to do so. I'm gonna kind of skip through here just a little bit. But the first thing that I'm just gonna run us through like 5 little takeaways that you can take with you from this presentation, ways that you can leave from here and immediately go about being the application for social health in your community. And the first is changing your language. So this quote that I just skipped over is a really beautiful quote that offers the word bonding instead of addiction. It's this idea that by changing our language, we can point more to this relational and social aspect of addiction and substance use patterns. Really, when we bond with different substances or behaviors like heroin or alcohol or stress baking, or any of the other things that we've talked about during this presentation, we are bonding, we are forming a relationship with that behavior or that chemical. It's just a more accurate use of language, and changing our language is what changes our reality. So using first-person language and connection-oriented words is a great way to move into applying social health concepts in your world and your community. I'd offer the word bonding instead of addiction. I'd suggest talking about returning to a pattern that I was trying to change rather than using the word relapse. Instead of using the word addict, you might just say this person is really struggling with trauma, or if it's relevant, in the conversation to talk about drugs specifically, that this is a person who's struggling with drugs or drug use. Rather than using the word clean, which implies its opposite of dirty, you might use the word substance-free instead. And rather than use the word junkie, which is really quite shaming, even when we're using it jokingly, right, and calling ourselves like a personal growth junkie, or I'm a reading junkie, remembering again these ways that we create subtle moments of shame You might instead use person first language. This is a person who uses drugs or who used to use drugs. This isn't about being just polite or politically correct. Every time we use connection-oriented language, we're actively implementing this relational model and actively assisting our community in destigmatizing experiences that drive us apart and sometimes drive people further into addiction patterns that can be literally fatal. So don't take it lightly as you're doing this. It's important work, just changing our language. The other thing I'll offer is to welcome open conversations about drug use and consciousness alteration. The way that we confront abstinence culture is to simply talk about it openly, talk about the ways in which I alter consciousness, to let go of the shame around the particular way that I alter my consciousness or that I see other people altering their consciousness, and talking about the different coping mechanisms that we all use, simply with more objective language. And something that I found works really well for me in all of this is to first just start to notice the ways in which you might be subtly shaming others or yourself when you talk about altering consciousness. I know a way that I do it all the time is kind of by laughing at myself when I name that I, watched more Netflix than I really wanted to, or, have been eating more desserts lately than feels good. That will usually come with some kind of like self-derogatory joke or laugh. And that's a really great little signal that there's some shame going on there and it's not an open conversation anymore. The third one that I'll offer is self-disclosing about your own personal harm reduction strategies. We don't have time to get fully into this right here and right now, but this idea that harm reduction only applies to IV drug use or to certain kinds of addictions is really false. It's relevant to, since we can all experience addiction, that's relevant to all of us. If I keep coming back to this Netflix example, there's things that I can do from a harm reduction perspective to reduce the amount of harm that bond it has in my life, right? I can limit the number of hours or change my password or something so that I'm not cutting myself off completely from the thing that I'm bonded to, but I'm putting limits and boundaries in to protect myself, to reduce the harm that I experience around that particular bond. We're not going to do this in the chat box right now, but these questions are helpful as far as serving conversations with others and myself that are more objective about addiction. Just simply answering the question honestly, what are you bonded to? And sharing what I'm bonded to. Talking about both the good and the bad. What part of this bond do I like? What part of it is serving me? What are the benefits of it? And what are the disadvantages of it? It really helps me to escape after the long work week, to dive into my favorite show. What I don't like so much is when I, watch it until 4 a.m. and then I'm so tired that I can't engage with what I had planned for the next day. There's always good and bad, and talking about these things more openly is part of what serves us in having more real conversations that are less embedded with shame. Number 4 is listening without an agenda. If you're curious about this, I really encourage you to check out SeekHealing's listening training course, where we talk about just some really basic, useful skills that we can use when we're listening to other people. I'm not going to go into them right now because we're already at 6:15, but I do encourage you to check out listening training if you haven't already. And the last one is to confront this way that we have in our culture of constantly fixing each other or giving each other advice, and instead just implementing a little check where we ask for consent. Hey, do you want to hear what I think about that? Or would you be open to some advice about that? And just presencing and making it clear that I'm not here to fix you, but giving advice is something I can do if it's something that you want. Giving each other more agency around the changes that we make is going to be really crucial to having interactions that feel good and are more healthy. So I really believe that by doing this, we can start to create a world that we all really want to live in, rather than escape from. And that's a world that we're all building together. And that's all I have for you this evening. Thanks for staying a little bit late. I'm sure some people will be going ahead and hopping off. Oh, thank you. I see your silent applause. I'm open to any questions, and I'll stay here for a couple minutes. If anyone has any questions, you can feel free to unmute yourselves.